Good day, everyone. Bonjour à tous. Welcome to the TB Talk series presented by Indigenous Services Canada. Bienvenue à la série Parlons tuberculose présentée par Service aux Autochtones Canada. Si vous voulez écouter en français, veuillez cliquer sur le globe terrestre en bas de votre écran et sélectionner français. Nous avons aussi mis dans le chat la présentation traduite en français en cas vous aimeriez le suivre en même temps. My name is Cynthia Tardevel. I'm a nurse advisor on the TB file at Indigenous Services Canada, and I'm joining you today as a guest on the beautiful, ancestral, and unceded territory of the Algonquin and Anishinaabe people. And I acknowledge wholeheartedly and with gratitude and respect the First Nations people who have lived on this land since time immemorial. The focus of today's talk is pediatric TB. In Canada, pediatric tuberculosis is largely a disease of Canadian-born Indigenous children, children born in high-incidence countries, and children of parents from high-incidence countries. Children under the age of 5 are at high risk of progression to severe forms of TB disease after TB infection, which makes awareness of pediatric TB critical for healthcare providers working with these populations. A lot of TB education is focused on TB as seen in adults and may not get into the unique portrait of what TB looks like in children and the measures required for testing and treatment. So we hope today's talk will help fill this gap. And so to start this talk in a good way, I'd like to invite Elder Syexwaliya to provide some opening remarks. Welcome, Syexwaliya, and thank you for being here.
Hi, Ochton. I welcome everyone. On Halthan, Squalwan, Quisclake, Cochnomi, Tenoyap, and NCII to Squal's to Seats. I'm really glad to see that you all came here today for this very important talk. It's really important that we take care of how TB is taken care of in the country, because in the past it was something that impacted a lot of our communities, and there were even special here in BC about 4 TB hospitals, and the care has changed since then, and it's more effective if we be able to take the preventative measures as well as the care as soon as possible and not have to be creating those TB hospitals that were really bad in the early 1900s. And so I raise my hands to all of you for the good work that you're doing and the care that you give to people. I'm going to just ask you all to come together with open our hearts and minds. We say our Shwalwin, total being, emotional, mental, physical, and spiritual health and wellness. And just open your hands. And my grandfather said we all have an inner energy. Every human being we receive from Creator through the top of our head into our energy, and we can send it to each other regardless of where we are. And I saw Star Wars not to Queen in the long ago, and heard Obi-Wan talking about the Force, and went, that's what Grandpa said, the inner energy, it connects us to everything in creation and to each other, and we can use it and send it to each other. So let's send the Force to each other and say a short prayer. And I'll close with a song and prayer. So I'm going to ask you to take a few breaths and ground yourself wherever we are, whether we're on the first or second or third, whatever floor of a building. We're still, I heard an elder say, older than me, we're still on Mother Earth. So let's connect ourselves to Mother Earth and everything within creation. And take a few breaths and say, Chenkwe Mentomi Kakakanik Chesiam, Yonso Tunoyap and Man Squawin to Squal's Deceits, asking you, Creator, to watch over, guide, and protect all your children gathered here today, and help us all with our Squawin feelings in our hearts and minds, our total being, emotional, mental, physical, and spiritual health and wellness. Asking you, Creator, to let us come together and Chomot Squawin with one heart.
Syexwaliya, I apologize for interrupting you. It seems that you've muted yourself.
Oh no, where did I mute myself? Right at the beginning?
Just at the beginning of the prayer.
Okay. I don't know how that happened, but Chen Quinman Tomi Kakakanak Chasiam Yonsion so Tinoyap and Manman Squawin to Squal's Deceits, asking you, Creator, to help each and every one of your children gathered here today and help us all with our Squawin, the feelings in our hearts and minds, our emotional, mental, physical, and spiritual health and wellness. Asking you, Creator, to let us come together and Chomot Squawin with one heart and one mind, and share our words that we speak and listen to with Winoxus respect, and be able to have a transfer of knowledge and information and experience so that we can, and different views and that different experience to be able to create a good solution and plans for the present and future generations, and to come together and work on the TB in all our communities so that there's plans in place for everyone. And asking you, Creator, to let us have a yet one health excellent work today. Tama Quetsi Snachum. Those are my words. I'll hand it back over to you, Cynthia. I'm sorry about that. I don't know how I muted myself. Must have been the force.
When I saw Curious, I thought your cat, maybe I thought it was him. Thank you so much for those words, for those thoughtful words, and for guiding us into this TB talk today, which I know for many maybe felt as a difficult topic. So I'd like to start with introducing our first presenter, Dr. Mahli Brindamour. She's a general pediatrician with an interest in global health, refugee health, and infectious disease. She has been working as a TB consultant with Saskatchewan's tuberculosis prevention and control since 2021. In 2027, she co-founded the REACH Clinic, Saskatoon's only multidisciplinary clinic dedicated to refugees. She does outreach pediatric clinics for the northern communities of Black Lake, Fond du Lac, Île-à-la-Crosse, and La Loche, and covers inpatient pediatrics at the Jim Patterson Children's Hospital in Saskatoon. She's currently on sabbatical leave from her practice to work on a MDR-TB program with partners in health in Mazuru, Lesotho, but graciously agreed to share her knowledge at today's event. So welcome, Mahli. The floor is yours.
Thank you so much, Cynthia. Thank you, Elder Syexwaliya, for this nice introduction. It's really an honor to be here today talking to you. I'm joining from Lesotho, where it's 7 p.m. And the sun is setting. It's 36 degrees, which is very unusual for this place where usually it's fairly cool, but I'm sure is a change of weather compared to Canada. It's also nice to see so many known names in the participants and people from home that I miss. So talking about pediatric tuberculosis, because it's time to crush it. So time to talk about it. We can go to the next first slide. I Thank you, Andrea. I think you're controlling the slide. So why do we talk about pediatric TB? So when it comes to children, not only do they face unsurmountable difficulties accessing care, being diagnosed and treated, but the underlying factors leading kids to get infected with TB are linked to systemic factors, making them vulnerable targets. As such, we say that TB is a marker of injustice and inequity, of what is wrong with our world, both globally and locally. It's still very much an issue to tackle in Canada, as Elder Syexwaliya has outlined earlier, and a difficult one to discuss. But it is preventable, it's treatable, and it's curable. We know what to do about pediatric TB. We just need to do it. We can go to the next slide. This is one of my heroes, and I see Melissa Smith in the participants. Melissa Smith is a TB nurse extraordinaire who works with me in Northern Saskatchewan and TB, and I know she admires Dr. Falmer as well, who unfortunately we lost in 2021. But this quote has carried me through med school, and when days are hard now, I think about Paul Farmer, and that the idea that some lives matter less is the root of all that's wrong with the world, and that together we can save lives. And that's the motto of Partners in Health, which I have the immense privilege of working for in Lesotho, and very much connected to all of the work that we are all doing in tuberculosis. We can go to the next slide. Now, if you can imagine that you are this child, this is my son who has graciously agreed to have his picture uploaded in this talk, who's 6 years old. On the shores of the Mesero Lake in Lesotho. And so imagine you are this child. You should be all of what it means to be a child. Grow, you should play, you should learn, you should giggle, you should wear Spider-Man underwear, you should be loved and loved back. So what goes wrong in a child's life so that the conditions surrounding him or her will make them vulnerable to TB infection and TB disease? Why would a TB bacilli pick him in particular, this jumping, energetic, happy creature? Why did it happen? Why did TB choose this child? We can go to the next slide. Which brings us to discuss who is most likely to get TB in Canada. Which children are the most likely to be affected by this burden? In Saskatchewan, where I usually work, the disproportionate burden of tuberculosis is carried by First Nations and Métis peoples. Again, this is yet another marker of the deep inequities that we live in, and I'm sure I don't need to remind you of this. So in Canada, generally, Indigenous children who are born outside of Canada, and among them children who are refugees, are most likely to get tuberculosis and get sick from tuberculosis. We can go to the next slide. Thank you. So again, in Saskatchewan, where I usually work, we've seen at least 4 tuberculosis outbreaks in isolated northern communities in the past 2 to 3 years. And what is unusual about these outbreaks is that about 50% or half of the cases are pediatric, so found in children, which is highly unusual compared to other outbreaks in Canada. So the incidence rates in the tiny communities that are affected by the outbreaks are similar or even sometimes higher than incidence rates that are seen in Lesotho, where I'm working at the moment. So a brief word on Lesotho, which is a tiny landlocked country completely inside South Africa. TB in Lesotho is the highest in the world. It's upward of 600 per 100,000. So the worst in the world. Yet despite TB being the lead killer of children in the country, the portion of all diagnosed TB cases being children are very few. It's not by chance that Saskatchewan, despite its central location in one of the world's richest countries, is now seeing tuberculosis at rates not seen in decades, in addition to the now well-established resorption of congenital syphilis, which we never thought we would see again, but I see weekly when I work on the wards in JPCH, and perinatal transmission of HIV. Again, we know what to do about this. This should not happen. And it's not by chance that Basotho children in Lesotho are dying from TB more than anywhere else. It's because infectious disease and poverty, infectious disease and oppression go hand in hand. And as usual, in times of societal stress, children are neglected and suffer. This is a well-known fact. We see this during war, we see it during environmental catastrophes. Children are always the last ones. In particular, when they were already facing deep inequities and injustices. TB is just the tip of the iceberg. Children who are diagnosed with TB are those who live in poverty, in crowded housing, suffer from food insecurity and starvation. The TB is only adding to the burden of injustice that they carry every day. We can go to the next slide. If we had a pill to prevent lung cancer, we would be putting it in the water. Yet there are less than 0.0001% of the Saskatchewan population that's diagnosed with lung cancer every year. So ultimately, what we need to ask ourselves is this: what are we doing to address the root causes of what makes kids sick in this place that we call home? What can we do about it? Now we can go to the next slide and change tone a little bit and go to a little bit more clinical discussions. So to understand TB, we need to understand the continuum of process, so the continuum of disease leading from TB infection to TB disease. Traditionally, we've separated latent tuberculosis infection, or LTBI, from active TB disease. And it's still useful to understand how this works in the body. And also the treatment are different for the two types of disease. But really now, in the past decade or so, we understand that from TB infection to TB disease is more so a continuum. And sometimes people will be at the very beginning of this continuum where they don't have symptoms, can't spread it person to person, and don't realize that it's in their body, basically. So the bacilli is in check by the immune system. And then from active TB disease, where they will be very sick, very symptomatic. And then they can go back and forth between the two. But for the sake of this presentation, we'll understand active TB as symptomatic with active replication of the bacilli in the body, and that can be contagious. And that can cause death if not treated. Now we can go to the next slide. Thank you. And so this table right there is why we freak out about peds TB. Why it's so important to diagnose kids early and to find them is because kids less than 5, when they get infected with tuberculosis, have such a higher risk of developing disease than adults. And that's particularly true for infants and toddlers. So if we look at babies less than 12 months, for example, 50% of them, when they are infected, will go on to develop disease. But 10 to 20% of them will develop the severe kind of disease, so a TB meningitis or disseminated miliary disease that has a very high mortality rate, as well as morbidity, and can be difficult to treat. Now we can go to the next slide. How do we find latent TB? There are 2 ways we can do, depending on what's available, with a MEN2 skin test or the TST, or with antigen-based tests or interferon gamma release assay or IGRA. IGRAs are available in Saskatchewan, but I understand that in Canada, the availability and the coverage and the feasibility of IGRAs varies widely. I tend to favor IGRAs when I can obtain them. For example, in the context of the refugee clinic, when we're not sure that people will come back for a second visit, the second visit for TST reading can be a burden on families. But it is expensive, and usually it can only be done in larger cities where labs are better equipped to do so. Sometimes it is better to use IGRAs because we don't have to worry about BCG interference. However, what I will say about TSTs is that positive TST is a positive TST. So regardless of the history of BCG, if the skin reaction is above the cutoff, then we treat it like a positive. Of course, it's not really helpful in active disease, but we'll come back to this in a minute. Okay, we can shift slide. And by coming back to this is what I meant is you see this hill, I'm going to die on this hill. I'm sure the people in Saskatchewan who are listening are laughing out loud because I talk about this very often, that a negative TSC or IGRA does not rule out TB. And I repeat this to trainees, medical students, residents all the time. It is a useful test, but it is only a piece of the puzzle. And the reason for that is, especially in kids, if they develop active disease, it means that their immune system has been overwhelmed by the TB bacilli, meaning their immune system cannot react enough when we test it for TSC or IGRAs. And so up to about 40% of cases of active disease, especially the ones who are sicker, miliary, meningitis, disseminated TB, will have a negative TSC or IGRA. So again, just a part of the puzzle and cannot be used on its own, yet still useful in our array of tools. Okay, we can go to the next slide. Oh, so TB 101, when to suspect TB. If you can remember only one thing from this presentation, is that TB in kids does not follow any rules. It's hard to find, it's sneaky, and ultimately we often miss it until kids become very sick. And most of the kids who are diagnosed with TB are found in Canada, that is, because of contact tracing. So the epi-link that we talk about often. And in these kids, because of contact tracing, if we find active cases, oftentimes it will be early. So the symptoms will be very subtle or even not present at all, especially in kids less than 5, even more so in babies. So the classic symptoms of TB, we know them well, right? Fever, fatigue, weight loss, night sweats, the 4 symptoms in the WHO that are used for screening, that we call the B symptoms. They're not that frequent in kids when we compare them to adults, or they're so subtle and so long-standing that they're easily missed. It just becomes part of the child's personality almost. Cough cannot be that dramatic, and any respiratory symptoms could be related to TB, including wheeze that can mimic asthma or bronchiolitis. Another thing to know is that young kids, particularly those younger than 5 again, have difficulty containing TB infections in one organ system. And so extrapulmonary TB and disseminated TB, meaning TB in more than 2 or more locations or 2 or more organs, is a lot more frequent than in adults or even teenager. Meaning that we need to have a high index of suspicion for pediatric TB. We can go to the next slide, which is a summary of all most common extrapulmonary presentation with associated possible symptoms. Again, it can affect any symptoms in the body. I think I've seen TB everywhere except the hair. I'm sure it can involve the nails. We've seen it in the skin. We've seen it in the GI tract, certainly, etc., etc., etc. Anytime extrapulmonary TB is diagnosed, it's important to look for pulmonary involvement in all of those cases. Usually in pediatrics, if we find extrapulmonary TB, with the exception of cervical adenitis, then pulmonary TB will be present as well. Because disseminated TB are 2 sites, it means that there's hematogenous spread. And then again, kids' immune system is not as mature as adults, and so they'll have trouble containing it to one organ system, especially once there is spread already. But again, the most common presentation are, of course, pulmonary, then cervical lymphadenitis. Osteomyelitis is quite common, the classic Pott's disease that we talk about. Meningitis is common. Abdominal TB can mimic anything also. So again, key to diagnose is to always keep TB at the back of our minds. We can go to the next slide. Okay, now we can keep a high index of suspicion, but how do we find it and prove it? Often in pediatric, we're not able to obtain bacteriological samples that are positive. So positive cultures, positive gene expert or TB PCR are the exception. So oftentimes we will have to make do with the epi-link and with the clinical case definition. The reason for that is that, again, in kids, a very small number of TB bacilli can make them sick. And because the samples are paucibacillary, then they're hard to find and they don't grow well on culture. So negative samples doesn't mean that there is no TB. It's just another piece of the TB puzzle. And the younger the child, the more frequent this phenomena is. So in babies, it's very hard to find. And so you can ask for samples from anywhere, any of the sites that you think can be affected. So sputum being the classic one, plus from everywhere. You can do blood for TB culture, urine for TB culture, for gene experts, CSF. Tissue biopsies are also very helpful. And the larger volume, the better. You need at least I know there are microbiologists on this call, and I call them often when I'm on TB call, saying like, I have a tiny sample of 0.03 mils. There's nothing that they will be able to do with it. You need large sample for your test to be good. One thing that I don't think is yet available in Saskatchewan anyways, I see that Camille Hamula is on the call, she might be able to comment later, but is urine lam. We have high rates of HIV in Saskatchewan, and urine lam, it works better in people who are living with HIV, the more immunosuppressed they are. So the lower the CD4 count, the more sensitive the urine lam is. It's an easy bedside point of care test that can be done, and it's very specific for TB. So we just need a drop of urine, tested for the urine lam. For people who are very immunosuppressed is very helpful. We can go to the next slide. But in peas, of course, kids don't tend to do what we ask them of. So I don't know if you've tried to feed a toddler at supper when they don't want to eat, but they don't really listen. So obtaining samples can be difficult. And mostly for sputum, they cough and then they swallow. So it's very difficult for a 3-year-old to understand that, cough, 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 and then they should spit it out. Some of them can do it, but it's rare. So the latest Canadian guidelines in 2022 actually advise sputum induction for kids above 6 months enough. It's actually been proven to be safe for babies above 2 months of age. There's a video link in the 2022 Canadian guidelines that I would invite you to look at, because that is a very helpful method. Now for kids, you need to induce it, and then you need suction to make sure that you catch the sputum before you swallow it. Gastric washings are also quite practical. They have a better sensitivity in newborns, interestingly enough. Otherwise, sputum induction should be better, as it's as good as just a regular sputum sample in an adult that doesn't need to be induced, for example. We can go to the next slide. Okay, and then once you have your sample, then you protect it with your life. You try to have 3 first AM sputum samples, but in kids, they're hard to get. So often we'll just get the one precious gastric washing and we'll want to send it for everything. If you only have a small sample, I would prioritize AFB and TB culture because that will be more definite. But TB gene expert is also very quick. You can have the results within a couple of hours, and the sensitivity is comparable depending on the site where you get it and the quality of your sample. It can be comparable to culture. Now, some centers will use the Gene Expert Ultra, which has an even higher sensitivity. But when I talk about higher sensitivity, we're talking about percentage in the 70s, 75%. So certainly not perfect. And then the AFB, you'll have the result within a few days. And then the TB culture, of course, it will grow faster if there's a higher load and the patient is very infected. But usually to confirm that it's negative, it takes 6 to 8 weeks before the final result is back. We can go to the next slide. Okay, this is just for reference. It's the sensitivity of diverse sites for Gene Expert and Gene Expert Ultra for reference. So again, if your Gene Expert is negative, it does not rule out TB, still could be. So to interpret with caution. You can do it on any site, but again, I feel like the wrath of the microbiologist will come on me because lots of these sites are not validated, and in a lot of provinces, in a lot of labs, they will only accept sputum samples. So you can do it on other samples. You can do it on CSF, you can do it on stool, you can do it on urine, etc. You just have to interpret it with caution because the results are only helpful if they're positive. We can go to the next slide. And so basically in TB for pediatrics, we rely on other things than bacteriological confirmation. So we can have positive TSC or AGRA, there will be abnormal imaging, and then Arguably, the most important one is the EPI link. It's your child at risk. You have documentation of contact. And then when we read the 2022 Canadian guidelines, they're even poetic when they talk about pediatric TB, and they say some of these cases may also be symptomatic if you're lucky, to tell you how elusive pediatric TB is. We can go to the next slide. Okay, so when to think about TB. If you're a resident working with me, you think about it all the time, all night long. Every time you see a child, you will say, I'm working with Dr. Brindamour, I have to mention TB. So this is true, but also we can be a little bit more specific. Careful exposure history is really, really important. Is there any history of travel? Okay, you live in the city, but you travel back and forth between the north or between reserves. Often people will do that, so that's important to document. Now, when you're treating infections repetitively without improvement, is there a bone infection that's not going away? Has the child been treated for pneumonia 3 times in the past 6 months and not gone better? But also in the differential diagnosis of things like inflammatory bowel disease, of any solid tumors, of any abscess growing anywhere in the body, TB should be in the differential diagnosis. All of these images are images of real cases that we saw in Saskatchewan, and we were told by radiologists and clinicians, TB, it's not TB, of course not. And then all of the gene experts were positive on brain tissue for this one, positive on bone for this one, and positive on skin sample for this one. And then, of course, when things don't make sense and you can't put things together, TB is often lurking in the background. We can go to the next slide. Okay. This is my interesting image and pop quiz. For those advancing the slide, there's a last, there we go, you can stop there. So these are all x-rays taken of children approximately of similar age. They're all babies and toddlers. The first one shows a cavity in the right upper lobe. The second one shows an opacification in the right upper lobe, but no cavity. The third one, I would say, is non-specific. There's a bit of perihilar thickening here and there, but really nothing exciting. And then the fourth one, despite the scary appearance of the thymus that can be mistaken for a mediastinal mass, is a normal baby x-ray. So now, which one is TB? The first one, even though cavitations are far from being classic in children, it's so rare that we see it. This child was a three-year-old who was diagnosed with tuberculosis and had positive induced sputum, had cavities. We will almost never see this because most of the time, chest x-rays with TB look like third x-ray. So very non-specific, very subtle findings, and it's still TB. There is a next, yeah, there we go. Okay, we can go to the next slide. So once TB is diagnosed, it's easy. I often have this conversation with the team back home. We know what to do about active TB. No question, we know what to do. It's treatable and it's curable, and the treatment in kids is very well tolerated. They tolerate their meds better than adults. They don't get as much liver toxicity. Once they're used to taking their pills, they take them well. I mean, it's not a walk in the park, but it's possible. There are more barriers, however. You can see the first image above is the number of pills that's necessary to take every day for treatment of multi-drug resistant TB, depending on the type. So the pill burden in tuberculosis is high, and we don't have a lot of nice options for children. We have big pills, they taste bitter, the solutions that we have, they're gross, and it really impacts quality of life to have a parent fight with a kid every day to give them their medication for, you know, upwards of 6 months. And so there are options. There are dispersible tablets, there are combination tablets that we can use, but those are not available in Canada. So we still struggle with children who are neglected from I don't want to say new technologies, but new options that are available elsewhere and would make their quality of life better, would make their treatment more tolerable. Yet, because they are children, I think, and they don't vote or pay taxes very much, then we don't have good options for them. This said, the TB team where I work in Saskatchewan, they're miracle workers. So they are experts in, crushing bitter tablets of rifampin and putting them in Nutella sandwiches, or Slurpees. I even saw them do energy drinks with my pediatrician school, didn't really like, but it was better than getting TB. We even have a well-known TB worker in one of the communities we work on who's been known to climb on a roof with her Nutella sandwich full of rifampin to feed it to the 8-year-old who wanted to run away from her. So it's a daily struggle to finish treatment. We can go to the next slide. And so in summary, again, I will repeat, we know what to do about TB. We know what to do for elimination of childhood tuberculosis. We don't need to have it. There is a map, we can follow the map, and eventually it will work. Because childhood TB is preventable, it's treatable, and it's curable. So that's my call to action for you today. Let's get on that roadmap and let's crush TB. These are resources that I find quite helpful. If we can go back, in particular, so the Canadian Pediatric Society, always a nice resource. The ENT-TB platform from the WHO actually has an app for your phone with each WHO recommendation that you can look up. There's doses for kids. It's really helpful app that I've been using lots in Lesotho. And then the Curie International TB Center has lots of resources for tuberculosis, for pediatrics in particular. There's a radiology handbook that you can download for free. And then the guide to the gastric aspirate procedure, which I often, people are scared to do it, but it's really, really simple and easy. And this one is very well explained. And if we have time, I hope I didn't talk for too long, then we can have a few questions, hopefully.
Well, thank you so much, Mahli. And actually, I forgot to mention at the very beginning, we will have a discussion period. We'll just invite Christine and Kelly, our other guests, to present just beforehand, and then we'll move into a discussion. So I wanted to say again, thank you. Your passion and care for pediatric TB is so evident, and every time I hear you speak, I learn something new. So you really highlighted just how complex the diagnosis is for a child with TB, and how important it is for us to always, I'm saying always, think TB, especially when seeing a young person who's been in contact with someone with TB, or TB is known to be in that community. Just so important to think TB. So so thank you again. I'd like to welcome our next guests, Christine Taylor and her daughter, Kelly. We're so excited you could both be here today. I know it took some coordination on your end, and we're just so grateful you're taking the time to share your experience as a family affected by TB. So I'll pass it over to you both to introduce yourselves.
All right, this is Dr. Duillo speaking from the side, so I'll help with the conversation. So go ahead, tell us where you're from, what your name is, and your experience so far with TB.
Yeah. My name is Christine Taylor. We're from north of Manitoba, and my experience with TB, TB came to our family 2006, somewhere around there, when my daughter Kelly was a baby. And
what was that whole process like at the time? Like, how did you find out? What was the diagnosis like?
oh yeah, and we were in a contact tracing. We were in a contact with my uncle. He already passed away a couple of years back, and that's when we know that we had TB.
And what was that like going through? Like, what did you feel at the time, and what did you understand at the time about TB?
Mm,
Do you remember the emotions you were experiencing?
um, the emotions were sad. Mm,
Yeah, it was a lot, it sounds like, hey?
yeah.
And so what's happened since then, because a lot's happened with your family since 2006. So what's happened since then with TB?
Yeah, we've had the TV on and off in our family.
For the last probably what, almost 20 years now, hey?
Yeah, and I like to mention my late great grandpa in 1940s. He had a TB too.
Mm.
Um,
What,
he,
what did you learn about him?
no, I I didn't know that he had TB, but I overheard my parents, my uncle, he had TB too, and he had I think he had a surgery. He had one lung too,
Mm.
and my late uncle, he had a surgery too. His lung was cut.
Is it damaged?
Yeah,
So did they remove part of his lung at the time?
yeah.
Yeah. And so what's happened since that time with your kids? Because that's how I know them. This is Dr. Duello speaking. I've met lots of Christine's kids. She has 10 kids.
Yeah. I have 10 kids and happily married of 20 years. And
I've met a few of your kids, hey?
yeah,
And we've had more active cases in your kids since then that have required treatment.
yeah.
How many times do you think your kids have needed treatment?
I think it started 2006, 2014,
Yeah.
2017, and last year 2023.
Yeah. And that was all the contact investigations those years that kind of brought
I
that
don't
up?
know. I don't know. We only had contact back in 2026.
And then it just sort of kept going, hey?
Yeah.
Yeah. All right, well, I'll let you off the hook right now. And this is Kelly, her daughter. So Kelly, just tell us a bit about yourself and your TB experience. How old are you now?
20 years old, turning 21 soon.
Yeah. And one of our nurses who's here first met her when she was how old were you? 3, we think?
3 or 4.
I think so.
Yeah.
A long time ago.
Yeah. And then that was the first time you were treated, hey, which you probably don't remember. And then what about the second time? What happened then? And when was that?
That was in 2017.
Yeah. So you probably understood a bit more, hey?
Yeah.
And what were you feeling at the time? Like, what was that like for you?
I was scared.
Yeah.
Yeah.
Why were you scared? What were you thinking was going to happen? Or did you know, or you just?
I was scared.
Yeah.
Yeah.
Do you remember what the treatment was like? Yeah. Tell us what that was like for you. Do you remember taking pills or liquid?
Yeah.
Yeah. Do you remember how it tasted?
It tasted nasty.
Yeah, it tasted nasty, hey?
Yeah.
Yeah, so what kinds of things did they do? Did they help you with that, or did you just kind of have to get through it?
It helped me a bit.
Yeah.
Not a lot.
Did they mix it with food, or do you remember, Christine, how they gave the?
I don't know. I had a lot of kids. I had a lot of kids taking the treatment.
Right. And most recently, another daughter of yours got very sick with TB, right?
Yeah, 2023, my daughter Caitlin spent a month in the city, 3 weeks in the hospital.
Yeah.
She lost a lot of weight.
Yeah, she's very thin, hey?
Yeah.
And what was that like?
Like as a mom, I had to be with her along the way, her sickness until she got better.
Mhm. And how has the medication gone for her?
It was going good.
Yeah.
Great. Yeah.
Yeah. Did she have any difficulties with it for any reason? Like related to pills or taste or anything like that, or?
Like I don't know,
Not sure.
not sure.
Do you know how Caitlin's been going? Like how her experience has been? Kelly? What have you seen?
How's your sister doing with it all?
Yeah. How do you think she's doing?
She's doing great.
Yeah.
Yeah.
But it sounds like she's still struggling a little bit, hey? And what she's struggling with? Her breathing, I think, right?
Yeah.
What's been going on with her breathing?
Did she run around and play, or is she short of breath?
Kelly? How's Caitlin doing now?
She's okay.
Yeah, her breathing is still an issue though, hey? Yeah. And so tell us a bit, do you guys know anyone else in your community with TB? Or have you heard anything about any other TB survivors in your community?
Yeah.
Yeah, what have you heard kind of through the community grapevine?
Yeah, I heard a lot of people had TB.
Yeah.
It all started, like I said, talking to 2020,
Yeah.
2006.
Yeah, yeah.
Right.
And so you know of other families,
Yeah.
that have gone through this too.
Yeah.
Yeah.
I myself had to be in a hospital tour.
Okay.
I think
I
that's,
don't think I knew that. Yeah.
I think that's, yeah, that 2026, I had to take 14-day treatment.
That in isolation, hey?
Yeah.
Yeah. And yeah, so unfortunately we were still doing that at the time. And what was that like for you being in isolation at the hospital?
Like I had to be there in order for me to get better too, and I had to leave my little ones behind.
How many kids did you have at the time?
3.
Mm.
I had a newborn baby, and I had to leave her
Oh gosh.
that time.
Wow. One of them. Yeah. And so you had to be separated from your baby, hey? Yeah. How did that affect you?
Leaving my kids behind.
Yeah.
I don't know.
Yeah. It's a hard thing to think about, I think, right?
Yeah.
So just gonna wrap it up, but if you had to tell people the most important thing you learned going through this experience, Christine, about TB, what would you tell people? What do you think is the most important thing we might not know?
As a mom, keep taking or take good care of your children and know what's best for them.
Good, that's good advice. And Kelly, what do you think from your perspective would be important for us to know when we're treating kids with TB? What lesson would you tell us that we need to learn? Not sure? Okay, that's totally fair. Okay. All right, we'll hand it back to you. Thank you.
Thank you. Thank you all. And Christine, from what I'm hearing today in our conversation yesterday, you're just the best mom. Like from what you've told me, you're there every step of the way with your children.
Yep.
Every step of the way. And Kelly, you too. It sounds like from our discussions yesterday that you're caring for your siblings who are going through this, and having been through it yourself can definitely adds. So yeah, thank you both for trusting us with your story today and
Yep.
taking the time to be away from your family and your home to be here. I'd also like to thank Amanda Witt and Dr. Rachel Duillo for connecting us with the Taylor family and supporting their participation. Dr. Duillo, she's one of Canada's top experts in the field of pediatric TB and the lead author of the Chapter 9 on pediatric TB in the Canadian TB standards, which I will link to in the chat. I highly recommend reading it to learn more on the topic.
Yeah, and I just want to say they're exemplary patients and like honestly role models for all of us. And I wish everyone did as well as they did. So yeah, again, we from here as well, thank you so much for sharing your story.
There's a lot of gratitude in the chat as well for sharing your story, and some questions which we'll get to shortly in the discussion. So I will now end the recording.